Coming up on the program, our healthcare experts discuss the latest in medical news from the previous month, and then they answer your questions.
Support for What's Health Got to Do with It is provided in part by the American Brain Foundation invests in research across the spectrum of the brain, knowing all brain diseases, disorders, and injuries are connected. There can be no cures without research. Learn how you can make a difference today at AmericanBrainFoundation.org. Rethreaded knows human trafficking destroys lives, but they also know it's not the end of the story. Rethreaded believes in the potential and power of all survivors to reclaim their lives. Visit rethreaded.com to learn more. And Elevate Med. Through mentorship, leadership development, financial literacy, a robust peer network, and tuition-based scholarship support, Elevate Med is dedicated to the next generation of diverse physician leaders as a tangible step towards the eradication of health disparities. More at elevatemed.org.
Hi, I'm Dr. Joe Sirven, a practicing neurologist at Mayo Clinic, professor of healthcare administration and policy at Arizona State University, and this is What's Health Got to Do with It, which looks at where and how healthcare intersects with your life, helping you get the medical answers you want. Coming up, it's our monthly medical roundtable, and we are talking the biggest health headlines from the past month, ranging from the danger of mini strokes, the effectiveness of Pepto-Bismol, pregnancy in hotter climates, to brain-eating amoebas. We have got you covered today. Then our experts answer your questions. But first, June was another whirlwind month in health news with headlines that sparked conversation and concern. And as we just mentioned, we are talking a lot about different topics, including at-home cervical cancer testing, mini strokes, Pepto-Bismol, brain amoebas, elderspeak, and pregnancy during hot weather. Joining us to talk about these topics are Dr. Joseph Driscowski, professor of neurology and practicing neurologist at Mayo Clinic in Phoenix, Arizona. Dr. Draz, it's always a pleasure to welcome you back.
Always great to be here. It's an honor.
Always a pleasure. We have Dr. Donna Ivory. She is a podcast host, an author, and also an obstetrician gynecologist. Dr. Ivory, welcome back.
Thank you so much. I really appreciate being here.
You bet. And Dr. Dacre Knight, he is an internist. He is a hospitalist, and he is also director of the Ehlers-Danlos Clinic and Mayo Clinic in Jacksonville, Florida. Dr. Knight, welcome back as always.
Thank you so much. Thanks for having me.
You bet. We're going to start with our first topic, which is the approval of an at-home cervical cancer screening kit. So in a big shift for women's health, the FDA approved at-home test kits for cervical cancer screening. These kits allow people to collect a sample privately and then send it in for HPV testing, a key step in detecting and preventing cervical cancer early. This could be a game changer for those who delay or avoid Pap smears due to time, discomfort, or access barriers. Dr. Ivory, I'm going to start with you today. How does this at-home test work? And the big question that I get from people who've asked me about this when we were covering it is, how accurate is this compared to what you would traditionally do when you go see your OBGYN?
Dr. Joe, thank you for that question. This is a big deal. And when we talk about an at-home test, ease of use is so important. And so when you look at the studies that supported this test, the ease of use was just amazing. All of literally like 96, 98% of the subjects felt that it was so easy to do. And they preferred it to a traditional screening with a speculum in the gynecologist's office. They also looked at, how does this test track with getting your Pap smear and HPV testing in the office? And the positive correlation, meaning the HPV testing being positive, was 98%.
Wow.
And then the correlation on the opposite side, meaning the HPV test is negative, was 90-something%. I think it was almost 92%. So it was great at coinciding with a positive Pap smear. And it was great and coinciding with a negative pap smear. And that's fantastic.
That is huge. Connect the dots for us. How does doing HPV testing, human papillomavirus testing, connect to cervical cancer prevention?
Well, as we've learned more about HPV and had 50, 60, 70 years worth of pap smear information, there is a correlation between HPV and cancer. So if you look at cervical cancers, they all had HPV associated with them. And I say all, but I'm going to really say 99% had had HPV associated with them. And then specific types, mainly it's type 16 and 18. But then we've got several other types. There are 12 other types that are also considered high risk for cervical cancer. And so the HPV testing is testing those 14 types. If they are positive, because those are the types associated with cervical cancer, then you need to follow up with a pap smear and or colposcopy to look with a microscope at the cervix and the cervical cells to see if there are precancerous changes. So that's the method to the madness when it comes to the HPV testing.
Got it. Dr. Ivy, are there any downsides or risks to doing this kind of screening at home instead of going to see someone like yourself?
I think the risks are negative, that they're none, really. You know, it's not often that somebody, to be honest, a woman's going to jam something up their vagina so hard that they're going to create a hole or something. That this testing is not, the size of this is no different than a regular tampon. And so usage in terms of risks are so low that really isn't part of it. I think the downsides concern more opportunities for women to not seek timely intervention and care. For instance, the HPV is positive, so let me get online and see what I should do. Let me try a castor oil pack. Let me try this. Let me try that. How long does someone try those things? When do they know to retest themselves? When are they going to come in to get care? Do they have an established OBGYN? And can they get in rapidly when they do seek care for persistent positives? Those are the kind of downsides.
Got it. We're going to pivot to another topic, and we're going to talk a little bit about a story of TIAs, that's transient ischemic attacks, otherwise known as mini strokes, and how they can have major consequences. So new findings indicate that these TIAs, transient ischemic attacks or mini strokes, can lead to the same cognitive decline as a full-on stroke. Researchers at the University of Alabama in Birmingham found that even if symptoms of a mini stroke resolve within 15 minutes to an hour, the result could lead to a long-lasting change in people's cognitive ability and even contribute to dementia. At least 250,000 Americans experience a mini stroke each year. Symptoms can include balance loss, changes in eyesight, face drooping, arm weakness, and speech problems. Those who experience a mini stroke, should seek medical treatment immediately if the symptoms seem to resolve on their own. Dr. Draz, we're going to point to you on this one. Remind us all, what is a transient ischemic attack, otherwise known as a TIA or mini stroke?
Yeah, thanks for this very important question, Joe. Transient ischemic attacks, the discussion has been around a long time. As you notice from the symptoms you described with the introduction to this topic, these are usually loss of function, as noted, weakness, numbness, tingling, vision loss, those kind of things, negative symptoms where you lose a neurologic function with this event. It's super serious. Like you said, you got to get to the doctor as soon as possible, but it results as a lack of blood supply. So it's a brief lack of blood supply, either from emboli or other form of lack of blood supply to the brain. And it turns out that when you have that, it causes a negative symptomatology. This is a really good study. There's over 30,000 participants in the study.
Wow.
And about 350 patients in that study had these TIAs or mini strokes. So they have a robust cohort of patients, and over time they notice the decline. Again, it's basically a lack of function that occurs acutely in the proper age group. So
Got it. What does this study tell us that's different or that we don't already know? I mean, how did you view this?
I viewed this as a sense of back in the day when we were both young neurologists.
A while
It
ago.
was like, oh, a TIA was considered better than a stroke, obviously, because it didn't produce a permanent impairment. The symptoms were transient as it describes, you resolve the symptoms resolved over time, but maybe they don't resolve as much as we thought, and it's more of a cumulative effect over time. It only makes sense, think of like a repeated head injury. If you have a
Yeah.
repeated injury, you get a concussion over time. Repeated concussions, repeated mini strokes, it makes sense. So that interruption of blood supply, even on a transient basis, has meaning in the long term.
What do you think is the biggest takeaway for the folks listening out there to kind of learn from this particular headline?
As you mentioned in the introduction, get attention right away. You want to treat all the symptoms that you can. There's good stroke management that occurs at this time, clot busting drugs, and you don't know what's going to happen immediately. You don't know in the short term, in the acute phase, of what's going to happen until it resolves or it doesn't. This is a very serious business. I would again treat the acute symptoms, but you also got to manage the risk factors that are common for people that make you prone to have stroke, and those include hypertension, cholesterol issues, diabetes, atherosclerosis, heart rhythm issues. But there's a whole host of other things that a stroke specialist can probably help you with if it's determined that these are not your causes of your seizures. And I would just remind the audience here, as a part of public health, stroke.org is a good resource for learning about stroke and learning about TIAs. It's a very good website.
Good advice. We're going to pivot to a very, very different topic, and I'm going to put this under the category, say it isn't so. The question I'm posing, is Pepto-Bismol worth it? Dr. Knight, we're going to point this at you. This is the pink standby in every traveler's bag. Pepto-Bismol, with its familiar promise to prevent traveler's tummy, has a new CDC-backed study suggesting it may not be living up to that promise. Researchers found no significant difference between those who took bismuth subsalicylate, that's what the main ingredient is in Pepto-Bismol, to prevent diarrhea, versus those who took a placebo. So what does this mean for our go-to gut remedy on the road? Dr. Knight, I'm waiting with bated breath for your response. What does this say, at least like in terms of what did this study, why didn't it find the benefit on something that's been around forever?
It's been around forever, and it's got this this neon pink glow to it, so you think it must do something, right? It must really have an effect. And it's interesting, and how it's funny, because I was looking at these studies, these reports, and the Pepto-Bismol does the branding of upset stomach, indigestion, diarrhea. Hey, Pepto-Bismol. It's kind of like a wide span of conditions that it's used for, and maybe it may be a little bit too wide from what this study is purporting. So what it was related to, now it's interesting because this is quite a news story, but what this was looking into was prevention of traveler's diarrhea.
Okay.
So there's a lot of things it didn't look at exactly, right? What Pepto-Bismol may still help with, indigestion, upset stomach, and however you define that. But as far as prevention goes, they had two groups of patients who were traveling overseas for at least a week, and they were given tablets to take, and another group that didn't take the Pepto-Bismol, and it didn't see any major significant differences between the two groups as far as who ended up having diarrhea. So that's what it was related to, prevention of traveler's diarrhea. Now, having said that, there's still a lot of potential benefit that can be had from Pepto-Bismol that wasn't studied. So that's where that news is focused.
So let me ask you this. So let me kind of widen out a context lens. If we widen it out, this is the first new study, at least on this compound, since the 1980s. And I guess I'd wonder, from a philosophical question, what does it say about, are there other like, household name products that we use that may not be as effective? Is that what it may be telling us, or how do you view it?
Well, that is a great question because some of these things are just taken on the surface that it's going to help. And I had a friend, colleague who was discussing this news story also, that and mentioned that someone reported like, well, my stool changed its color, so it must be doing something, right? It must be helping, right? And you just kind of take it as accepted fact that, okay, this is what everyone's doing. It should help. But no, I think it gives good reason why we should be looking at these things and things. And having said that, though, there's a lot of real world data, so to speak. There's been a lot of people who have been using Pepto-Bismol since the 1980s, and so you would think that if something was dramatically shifting, about the safety and such, then we would know about it. So that's reassuring, and generally that's how those studies would go. They first make sure that the safety profile is good, and then the efficacy kind of something that would be looked at over a longer term period. And here we are. It's been quite a long term for Pepto-Bismol. So yes, very much worth looking into that, just to give patients the best sense of understanding when a doctor is giving them advice about what to do when they're traveling or they have stomach problems and things like that.
My last question on this topic is, I still have my 3 ounce of Pepto-Bismol that I have in my little traveler's bag that I go everywhere with. What are your current recommendations with regards to using this, especially if you're going to areas where there's higher risk for food or waterborne illness?
Yeah, well, so definitely be aware of that. I don't think you need to take the Pepto-Bismol out of the travel pack yet. I think there's still certainly some good use to be had from it. And maybe so in the case where you have symptoms that have already presented, but not so much as preventing them themselves. So yeah, and also I think maybe this is good news, because I was looking at this study, and they had, I think, an average of 10 days what someone's traveling, and they're having to take 4 tablets a day. I mean, that's quite a lot. And thank goodness there's the tablets now instead of the liquid. You'd be taking gallons of Pepto-Bismol if you're going abroad for an extended period of time, and if you were trying to prevent it. But no, I think in the case where you have symptoms arise, whether it is heartburn, indigestion, upset stomach, or diarrhea, fine. That it could be still valuable in those sense. We haven't done those studies yet, so maybe we need to do those in the future. But to your question about prevention, yeah, that's the biggest part of it, what you can do for infection prevention. And as the adage goes, if you don't cook it, boil it, or peel it, then don't eat it. And there's of course lots of fancy filtration systems and things now that you can do to prevent diarrhea. And there's generally 2 groups when we're talking about infections abroad. There's one group that may have some upset stomach, or some stomach problems over 24 hours and it goes away. There's generally not much that you need to do about that. But if it's prolonged, then it may require a course of antibiotics. So there's still a role for that too. But yes, being safe, washing hands, all of those things would definitely be in your favor when you're traveling.
Great advice. And to all of our listeners out there, you're listening to What's Health Got to Do with It on WJCT News 89.9. I'm Dr. Joe Sirven, and if you're just joining us, it is our monthly medical roundtable, and we want to hear from you. Tag me on social media at JSirven. We're going to switch to yet another very different topic now. And this is one that seems to always come up in the summer. This is about brain-eating amoeba, very happy topic, from using, in this case, a nasal irrigation system. Dr. Draz, I'm going to point this one at you. This is an unusual, very tragic case out of Texas that made national headlines. A 71-year-old woman died from a rare but deadly brain infection. This is from the brain amoeba I'm talking about, after using tap water in a nasal rinse. The culprit, the amoeba, is called Naegleria fowleri, commonly known as a brain-eating amoeba. It's a rare infection, almost always fatal. So I guess the simple first question is, what is this thing? What is? I think we every summer we talk about
every
this.
summer. Yeah, we've talked about it before. It gets headlines because it is such an odd thing. Naegleria fowleri is a one-cell organism, and it enters the body through the nasal cavity. At the top of the nasal cavity, your cranial nerve 1, which is your sense of smell, provides your sense of smell. It invades through cranial nerve 1 to the base of the brain, and then it starts going in and basically infects the brain and just basically causes a meningoencephalitis, which is inflammation of the meninges, and encephalitis, which is an inflammation of the brain in an infectious manner.
Okay.
It quickly destroys tissue, and it's very hard. Once it's in there, it's very hard to get out of it. I would like to say though one thing, if I could.
Sure.
This hit my listserv on of must read kind of things,
Right.
and I looked into it a little bit more. It was tap water, but it was tap water from an RV.
Okay.
So this was held in a warm, still tank. It wasn't tap water from originally probably was tap water from some source, a municipal source of some
Right,
variety.
right.
But this was sitting in a tank in an RV. So that may be a little bit of a different wrinkle.
Well, when we normally talk about this, we typically talk about it in the setting of someone in a lake or something along those lines.
Yep. Yeah, exactly. Lake, it's fresh water. It's not salt water. It's freshwater lakes, rivers. And I remember as a resident, we got one from a spelunker, a caver. And
wow.
They were coming across the Southwest, and they came to our institution with the signs of meningoencephalitis or meningitis encephalitis. And it turned out to be that. They said, well, we were in a cave a couple of days ago. We were freshwater diving in a cave, and that's what it turned out to be.
How fast does the symptoms progress? I mean, is this something that once you have it, it's too late?
Yeah, it's pretty quick. It's virtually 100% fatal from all accounts. You have to have a high index of suspicion because it is so rare. There's usually about 10 or so people a year that get it, but it always seems to make the headlines because it's almost like a plane crash. It's such a dramatic thing, and it's you have to have a high index of suspicion, and there has to be a history of. This one's a nasal rinse, but like I said, you can spelunkers and hot springs and those kind of things. It's hard to treat. You treat it with IV antifungals, but sometimes we'll put it in and around the brain as well in the subarachnoid space. So.
Let's talk about prevention. What are the safe practices? In this case, I didn't think we'd be talking about a nasal rinse, but for using a nasal rinse, or for that matter, the typical story here, swimming in warm, fresh water.
Yeah. Make sure you hold your nose. Use a nose clip. Try to keep your head above water if you want to be ultra safe. There's no way you can get in otherwise, really. Avoid shallow water. It tends to live more in shallow water. And if you're using it for like nasal rinses and sprays up the nose and that kind of thing, make sure you use distilled water or boiled water to irrigate. I use a bit of a nasal rinse, but it's a canned product that's sterile, and so it's not to scare everybody. This is water that's been sitting around somewhere. That's it's got to be boiled or distilled or very clean. Just make sure your source.
Got it. Okay, good advice. We're going to switch to a very different topic. And this has to do with looking at, as we are in the midst of a heat wave at this time, that extreme heat is making pregnancy riskier for millions, new report finds. So a new analysis from Climate Central is raising alarms about extreme heat endangering pregnancies around the world. So over the last 4 years, nearly a third of countries that Climate Central surveyed experienced an additional month of some type of pregnancy heat risk days on average, according to this report. So high temperatures evidently are linked to complications like preterm birth, low birth weight, and even stillbirth, making this a growing global health concerns. Dr. Ivory, I'm going to ask you to break this down with us. The first question is, how does extreme heat impact pregnant women and the developing babies?
I mean, that's a two-part question,
Sure.
and it's very important. So when you talk about pregnant women already are using reserves of their physiology to generate extra heat and whatnot to grow a baby.
Okay.
And so to be in a position where then they overheat, their compensatory mechanisms fail quickly because they're already using so much of their reserve. When we talk about developing babies, it's the environment. If the incubator is too hot, then what does that do? In the first trimester, it increases miscarriage risk. And there are 2 studies, I believe, that talk about increased in cardiac defects. When it comes to the second and third trimester, then we start looking at the risk of preterm birth, some risk of stillbirth, but really the risk of preterm birth, and then the sequelae from that.
So in general, I'm hearing you describe different things happening during the different stages of pregnancy or these trimesters. Is there one trimester, the early one, the third one, that's the most important, or is it just spread throughout?
It's spread throughout. It's spread throughout because it certainly you don't want to have a 7 or 8 week fetus and you've had a patient with a heat stroke. You're certainly going to worry about what's happening to that baby. And going forward, even if there are no other heat issues, the exposure has potentially created damage. When we talk about preterm labor, there are so many other factors, but we know that if the mom is compromised, the pregnancy has much more risk of being compromised. And so second trimester is probably more worrisome because survivability, morbidity with preterm birth in those ages are more significant than in the third trimester. So I think it's all over the place.
Okay. Here's the question. I'll be honest with you, I can't live without air conditioning in the summer months. So if a pregnant woman doesn't have access to air conditioning in this heat, what are some of these practical ways to reduce heat-related risks? What would you suggest in that scenario?
Well, some of it has to do with acclimation to the environment. And so a 93-degree day in Florida, where it's hot and humid routinely, may not cause the same type of difficulty as a 90-degree day in Maine. And so we look at those things. But one of the things that we have to pay attention to is that 62% of getting rid of heat is just radiating that heat off of your body. And so being in a position where there is airflow, there are fans, that is helpful. Staying hydrated is so important for women, so important during pregnancy, because the need to continue to have excellent blood flow is supreme. And so you've got to stay hydrated, got to stay balanced with electrolytes in the setting of all of the sweating and potential other mechanisms. You're breathing harder, you're breathing faster. Those things happen for pregnant women much quicker with much less increase in heat. And so that exposure is important to have, the exposure to that heat is important to make sure you're ahead of the game with hydration.
Got it.
Fans, I have definitely reduced the workload on women who are in situations like warehousing, delivery drivers without access to air conditioning in their cars. Definitely reduce the exposure to prolonged excessive heat.
Okay. I appreciate that. We're going to switch to a very, very different topic now. And this has to do with something called elderspeak, or better put, the perils of elderspeak. So it's almost a meme. It's almost a joke these days. You've heard it before. Lines like, "Time for our bath, sweetie." Or it might sound harmless or even caring, but for many older adults, that kind of elderspeak feels patronizing, infantilizing, and deeply alienating. So a recent New York Times article highlights how this well-meaning but ageist language leads to frustration, resistance to care, and even increased use of antipsychotics. Fortunately, experts are fighting back with education and empathy. Dr. Knight, how do you define elderspeak? And I mean, this is something that, I'll admit I've on occasion gotten there. How are we doing? And then realized we shouldn't be using collective pronouns. But how do you define it?
Yeah, and I think to your point that I think it's done with good intentions, and that's the tricky part. It's why it may be difficult to recognize. But I think you summarized it well. It's generally described as communication that sounds like baby talk,
Yeah.
Or using diminutives. So sweetie,
Yeah.
dear, or maybe some kind of talk that's overly nurturing, and yeah, it can be. Problematic for some who are on the receiving end of it.
It's interesting because they had this program that they invented called the chat program. And can you talk a little bit about what that was, what they did in that study?
Sure. Well, to the point about elder speak in general, like, you may hear about it and you think, okay, yeah, someone was trying to be, well-intentioned, to be polite and to be careful of someone's cognitive abilities and things like that, but they may not receive it well. So what was interesting is it was actually studied, and they compared groups, and they were looking at behaviors in elderly patients and who were showing some type of like resistance behaviors, and whether they didn't want to take their meds, or they just weren't kind of cooperating with staff and just kind of general care needs. And they the research observed that those who were receiving more of this quote unquote elder speak were actually had exhibited more resistance behaviors. So then they devised some programs and things that could help intervene and reduce elder speak in nursing homes. And that's what this chat program is. It just stands for changing talk. And so it was some educational tools to staff, some videos and things like that. And they noticed when instances of that dropped, and then those resistance behaviors also dropped. So it, evidence-based, clear indication that, there could be damaging effects, even if it is well-intentioned.
I guess the biggest takeaway question for us is that if someone is listening as a family member or caregiver, or maybe they're in healthcare, what are the right ways that we should, what's the common sense way that we should be making sure that we use the right respectful language, especially with an aging loved one?
Yeah, that's it, because loved ones, we generally want the best for them, and so when we think that maybe we are doing the best thing by using this kind of language and nurturing and things like that, so we may go overboard inadvertently, and then it actually has an opposite effect. It's it just adds to the isolation and depressing effects of getting older and losing your abilities and limited activities. And so I think just knowing that this is an issue, obviously, speaking to a loved one and an elderly person with respect, but I think, just giving them the benefit of the doubt that they may still receive and understand the information you're trying to give well enough. And if they have some difficulties, then it needs to be repeated and things, that's fine. Or, to tie into what we were talking about earlier, is repeated TIAs. Yeah. I mean, dementia is a growing issue. I think I saw recently that there's a patient diagnosed with Alzheimer's almost every minute. So,
wow.
I mean, it's clearly out there. So knowing how to handle these is important for all of us. I mean, we're all going to be aged if we're so lucky one day. And so we want everyone to be treated respectfully. So I think just knowing this issue, and then giving someone the benefit of the doubt who's elderly, that they may comprehend, they don't want to necessarily be treated like a toddler. They're still elders in many societies are very well respected, and we should still keep that and maintain that level for them.
Up next, our experts answer your questions, and we'll be right. Hey, it's Dr. Joe Sirven. I have a new show called This Week in Health, and it's part of WJCT News Now. Local news you can listen to anytime, anywhere. When you sign up, you'll unlock 4 local podcasts delivered straight to your podcast app. I break down the week's biggest health headlines and what they mean for you. Start a free 30-day trial at wjct.org/newsnow. And if you like it, become a monthly donor to support WJCT Public Media. Back.
Did I get a letter? Did I get a postcard? Woo, Mr. Postman.
Welcome back. I'm Dr. Joe Sirven, and this is What's Health Got to Do with It. Our producer, Stacey Bennett, joins us now with questions for our experts from our listeners. Stacey, how are you?
I'm great. How are you, Dr. Joe?
I am hanging in there. What do you have
Wonderful.
for us?
Well, this first one comes from Tracy out of Savannah, Georgia, who says, I'm 52, run a small catering business, and lately I've been forgetting where I parked or why I walked into a room. Is this just stress?
Dr. Drass, we're going to point this at you. We heard Dr. at night tell us about how many Alzheimer's cases there are, but I don't know if Tracy falls into that category. Help us out.
I forgot the question. No, I'm just kidding.
Oh, that's terrible.
No. This is such a very common question that many primary care providers and neurologists see over the years. You're worried if it's a neurologic symptom. If you're worried about pre-Alzheimer's or mild cognitive impairment or frankly an Alzheimer's disease. What I would say to Tracy and Savannah is this: it's very common for us, especially as we approach, in the 50s and 60s, for this to happen. Often it's a sign of lack of sleep or stress or other really easily explainable issues. But if there really is something to it, I would say get it checked out if you're really worried about it. And you can either start with your PCP or neurologist, primary care provider, your neurologist. Get a full history and physical and exam, and get a family history would be important in this particular case. In the office, they can do baseline screening, memory testing, such tests as the Kochman or the MoCA or the mini mental status examination to kind of get a feel for where you're at with regard to your memory. If there's something of concern, the practitioner will often look for treatable causes, and I think that's where most of us end up in the beginning. Look for treatable causes with potentially imaging labs such as B12, thyroid, just some general screening labs. If you recall that on our last roundtable, Billy Joel had some issues with. He had some issues with this, and it was found on imaging. So. You do find something that can be treatable. And if you do, you want to get it earlier rather than later. So I wouldn't delay a whole lot. But if it becomes a persistent issue, get it checked and, look for, if you need to, you can get a battery of neuropsychology testing. But that comes down the road. But just, pay attention. If you notice it, it's worth looking into, in my opinion. So.
All right, Stacey.
And can I jump in?
Yeah, sure.
Yeah.
And I only want to jump out there and say, if Tracy from Savannah is female, that sounds like menopause.
There it is.
There you go. There's another possibility. I love this. Thank you.
That's great. Yeah.
All right, Stacey, what's our other question?
Well, from Birmingham, Alabama, Amanda says, I'm pregnant with my second child and constantly losing my phone, my keys, and even my toddler once at Target. Please don't tell anyone. Is pregnancy brain real?
Well, I hope that it depends how many listeners we have for Amanda in Birmingham. But I think you hear a theme here, Dr. Ivory. Can you answer Amanda, please?
Oh, yes. Amanda in Birmingham, a lot of things are called pregnancy brain that are going on in pregnancy and postpartum. And so you have high progesterone levels. You have a different type of estrogen running around. But what stands out for me is that you have a toddler.
Yeah.
And let me tell you, there's pregnancy brain, and then there's dealing with a three-nager. And so I always tell you to just kind of look at your schedule, do what you can do. Don't try to be a superwoman, and stay hydrated because it's hot these days, and ride through it.
Such sage advice, Stacey. What else do we have?
Daryl in Jackson, Mississippi writes, Every time I go to urgent care, I hear a new itis diagnosis, bronchitis, gastritis, you name it. Should I be worried if my symptoms don't end in itis?
Dr. Knight, this sounds like a question for a Latin teacher, but I'm gonna aim it at you for Daryl.
Yeah, all those long medical terms and Greek or Latin. It's all Greek to me. And actually, this itis, I think, is a suffix from Greek, and all that
Okay,
means
then
is
I'm corrected.
inflammation. Yeah, so inflammation of any type, and you can have inflammation in every organ system in your body, as you imagine. So arthritis would be joint inflammation, right? Gastritis, stomach. So it's kind of a collective term, I think. But to your question, should be worried? No, I mean, if it doesn't end in itis, there can be also medical conditions that are not related to inflammation. So it's kind of interesting here. Actually, humorous in some ways. I remember hearing just a few days ago that someone was complaining about summer coming up now, and usually when you get all the movie sequels, they described it as sequelitis.
Yeah, that's
Too many
true.
movie sequels over the summer. So yeah, any type.
I saw that trailer for Jurassic Park, and I was thinking the same thing. So
Yeah.
how many times
Just
did you
reuse
watch
it,
that?
yep.
Yeah. Stacy, what else do we have?
Javier from Tucson, Arizona asks, I'm a high school teacher. I'm on screens all day, Zoom, grading, TikTok for fun. Can all this screen time rewire my brain, or is that just another internet myth?
Dr. Draz, we're asking you to be a myth buster here.
Mythbuster, yeah. Screen buster.
There you go. Help Javier out. If that, it's an interesting question. When the way we all consume information and interact with each other is all online, it seems. What does that do?
Well, it's a complex issue. It turns out that probably yes, screen time, the amount of screen time can potentially rewire the brain, especially in the developing brain. There's been some studies that show that there's some cortical thinning that occurs when we're on a computer a lot. So, but it's a very complex issue. When we're, again, young neurologists, we thought, oh, the brain develops and you're 25 years old and everything's good. But the brain turns out to be very plastic, it turns out. And these are the kind of stimuli that do change it. Negative part of it is it can impact our social skills, our interpersonal skills if we're on the computer all the time. Some people have develop an addiction to the to screen time. That's definitely a change in the brain. Poor concentration and focus are some of the another negative aspect of being on it too much. But on the positive end, we have educational opportunities, and we can interconnect like we're doing here today. I mean,
that's true.
Without the screen time, we wouldn't be able to do that.
Yeah,
So
I like
it
the
has
positives.
both. So the answer is moderation probably is a key to things, as in all things medicine, but to be determined. Interesting studies going on. So the answer is I think it does. And if you think you're getting too much, I probably would say you're probably getting too much.
Yeah, one of those I saw, I think is maybe out of MIT, and they were actually looking at not just screen time, but AI use, like using large language models for work all the time. And actually there was a difference between those who did and did not use, and basically more of an effect on those who are using a lot of AI. So something to think about in the future too, is that's growing.
You mean not utilizing their own brain and
Exactly.
Yeah, exactly. I totally agree. The brain likes to be exercised. It likes to be challenged. Yeah.
I love this. This is great. Stacy, what else do we have?
From El Paso, Texas, Gabriella asks, I'm 29, healthy, and I keep hearing conflicting advice about pap smears. Do I really need one every year, or can my OB and I take a little break?
All right, Dr. Ivory, we talked a little bit about this in that at-home screening test, but kind of directly address Gabriella's question. It's a good screening question.
Well, what ends up happening is that we talk about pap smears, but we're evolving in terms of how we diagnose who's at risk for cervical cancer, because that's the reason pap smears were developed in the first place. So there is some pushback in terms of gynecologists, women's health providers. And if we don't do pap smears, then when are people going to come to the office? And unfortunately, I think that guides some suggestions of getting a pap smear every year. And the bottom line is patients aren't obligated to be in a position to have to keep us open We need to be offering what it is that is needed to keep people healthy.
Mm.
And that's a hard pill to swallow for a lot of OBGYNs, but there are so many opportunities to help in other areas rather than doing quote unquote unnecessary pap smears. So pap
God.
smear every 3 years
Okay.
if the previous one had been negative. If the HPV and the pap are negative, potentially every 5 years, especially over the age of 30. And if there's a positive HPV, then that needs to be seen. If patients are not in a mutually monogamous relationship and therefore their exposure to HPV is significant, then the notion of waiting 3 years or 5 years is more worrisome. And that's where some of the confusion comes in. It's in the fine print.
Got it. All right, Stacy, what else?
This comes from Tallahassee, Florida. LaShonda writes, I'm a grad student working 2 jobs and my left eye twitches every time I'm stressed or sleep deprived. Is my brain trying to send me an SOS?
Dr. Tress, actually, I remember when I've been on call at times, and the next day my eye will not stop twitching, and I'm exhausted. Can you talk a little bit about what LaShonda's talking about?
Yeah, I think LaShonda has a neon sign over her house that says, "I am stressed." Okay, grad student, 2 jobs. I don't think anybody on this panel has not experienced the
Right.
same phenomenon.
Right.
You add a little caffeine into it. It's just a mix for this. It's just a setup for this. The brain is probably sending you a message. You probably need, instead of an SOS, save our ship. It means save our sanity.
Yeah.
We'd have to do things that are kind of reasonable. Your body is, the mind body interaction is very important. And having these twitches go on, as long as it's not persistent and as long as there's no other symptoms or signs associated with it, it's usually a benign condition that is indeed associated with, again, too much caffeine, energy drinks, and too much stress. So the things to try would be consider, getting your rest, finish that degree as fast as you can.
Yeah.
Avoid stress as much as possible. Do some yoga, meditation, stress, physical exercise, probably helpful. All those things would be helpful. And LaShonda and beautiful Tallahassee, I wish you good luck. It's worth it. Hang in there. This too shall pass, hopefully. But if it doesn't, go see somebody for it.
There we go. Stacy, what else?
Charlene from Charleston. She's 48, suddenly hot, moody, and losing sleep. She says, my friend swears by black cohosh. Can you treat menopausal hot flashes with this supplement?
Dr. Ivory, I don't. We've talked about different management with you on menopausal symptoms, but I don't think we've ever talked about black cohosh. Can you talk to us about that?
Sure. When I talk about black cohosh, that's one of the more popular self-help herbal type remedies, over-the-counter type remedies. And I'm a big believer in self-help. One of the things about black cohosh that's important is that it's gotten popular because it came out of traditional Chinese medicine formulas, but it is rare that a traditional Chinese medicine formula won't add dong quai to black cohosh. So black cohosh by itself is usually not necessarily recommended unless it's with dong quai. Now, I think this goes really with the Pepto-Bismol discussion. When there are over-the-counter opportunities, I like patients to take self-remedy under their wing and try some things and see if they work for them. We can't ignore the placebo effect. We think that there's some self-healing opportunities that get turned on by the belief that what you're doing is working. And I don't have any problem with that. It's how long are you going to take those things before you notice they don't work? Do you take them for severe symptoms? No. But mild to moderate hot flashes in an otherwise healthy patient, go for it. I don't see anything wrong with that.
Okay. We have time for one more question. Stacy, what is it?
All right. From Marcus in Mesa, Arizona. He says, I just spent 5 days in the hospital with my dad, and I was amazed. How do hospitalists keep track of so many patients?
Dr. Knight, I know you do some of this work. I've always amazed, especially when I used to do service and you'd have these long lists of patients. Talk to us about how, like, to someone who doesn't know, isn't in this world, how do you keep track of so many people?
Yeah, my goodness. And we're talking about stress. Yeah, I mean, this you have this panel of patients that it grows before your eyes. And yeah, I still do some of the hospital rounds. I did work full time as a hospitalist in St. Louis prior to joining Mayo Clinic some years ago, and it is incredible to think. And I think this listener, made a good observation. Is like, how do you possibly keep up with it? And I kind of asked myself that at the same time I'm doing it. Like, there's so many patients, so many complications, and there's some training that's done for this. So in our residency, just give a junior resident a couple patients to fall in a hospital. They get to be more senior, then they can double that, and eventually you're an attending, and you can see a larger set. But there is certainly a ceiling on that, because you're just going to be delivering poor care if it gets to be too thinned out. There's definitely a lot of technological tools that we've been able to benefit from over the years. So electronic records, and I know as much people bemoan those and the clunkiness of them sometimes, it really helps for keeping track of laboratory data and vital signs and things like that. So you can have access to a larger number of patients. But really, I think this goes to show this is a whole nother discussion for another day, but just kind of the healthcare practice where we are when people talk about sick care and health care. We really, it is in our interest to try to keep patients out of the hospital for these reasons, because staff can be overburdened and things like that. And so we don't want the hospital care to be kind of the end goal. We want to do as much as we can. And so if this is the last question of the day, then I think it's perfect, because all of these things that we're discussing now of what we can do to prevent and share knowledge and educate others to improve their health and maintain good health so they can avoid the hospital for themselves and loved ones. And that is ideal.
I love it. We have been talking to our A-team of doctors, Dr. Dacre Knight, practicing internist, head of the Ehlers-Danlos Clinic at Mayo Clinic in Florida, Dr. Donna Ivory, an OBGYN podcast host, author here in Jacksonville, Florida, and Dr. Joseph Driscowski, practicing neurologist at Mayo Clinic in Phoenix, Arizona. Well, that's our program for today. We hope you've enjoyed our show. If you missed anything, you can listen to the full episode at wjct.org and on your favorite podcast app. Thanks to all of our guests. Our executive producer is David Lutkin. Stacy Bennett is our producer. Brady Corum is our director. Caden Collins and Caroline Kahn are our researchers. If you have any questions about this or any topic, let us know by calling us at 904-358-6362. Email us at health@wjct.org or tag me on social media at @JServin. I'm Dr. Joe Sirven, and you're listening to What's Health Got to Do with It on WJCT News 89.9 Jacksonville. Thank you for listening, and stay in touch.
Support for What's Health Got to Do with It is provided in part by the American Brain Foundation invests in research across the spectrum of the brain, knowing all brain diseases, disorders, and injuries are connected. There can be no cures without research. Learn how you can make a difference today at AmericanBrainFoundation.org. Rethreaded needs you to make a difference in the lives of human trafficking survivors. Learn more about supportive services and an array of survivor-made products at rethreaded.com. And by Neurelis, a leading neuroscience company focused on the development and commercialization of therapeutics for the treatment of epilepsy and other neurologic disorders. The company's unique drug portfolios strive to address unmet needs in patient care. Learn more at Neurelis.com.